Hello. We'll be starting our session in a while. Okay. Please just grab your Pathoma book. So today we are going to revise everything which Dr. Moaz discussed regarding lung cancers. We'll also be discussing the pulmonary infections. Along with that, we'll be doing some restrictive lung diseases, right? So those who do not have their Pathoma, kindly just keep up on your Pathoma because we are going to discuss the entire things from Pathoma, and I'll be marking the UWorld MCQs, the high yield stuff. So that's really important. Okay, so I'm waiting for you guys. Just please, open your Python. Hello. Are you guys able to hear me? Hello. Hello. Please respond. Are you guys able to hear me? We are starting our session.
Yes,
Hello.
doctor.
Okay,
Yes,
that's
yes.
great. That's great. Okay. So today we'll be discussing. Okay, first of all, let me just share my screen. So today I'm basically using my phone for the lecture. So I want to, do it from Pathoma. So I'm just opening my Pathoma in my phone. Can you guys see my screen?
Yes.
Okay, that's great, right? So today we'll be starting with lung cancers. Okay. Before discussing cancers, you should be having a concept. When is the cancer like normally in our body? How does the cancer develop, right? So for that, you should be knowing the definition of cancer, right? I'll be making it like right from the basics. Then we are going to build our foundations on that. So what is cancer? Cancer is basically an abnormal growth of your cells. That's basically known as cancer. So remember, whenever we have an abnormal growth of cells, my question for you guys is, do that abnormal growth or a big tuft of cells require blood supply?
Yes.
Hello? Perfect. So it means that whenever we have a big tuft of cells which are growing abnormally, it would be having a lot of blood supply as well, right? So keep in mind, whenever we have cancers, those blood vessels can rupture. We can have, you know, if it's cancer of your GI, we can have like, in some condition, hematochezia or blood in the stools. If it's a cancer of, let's suppose, any kind of tumor of your renal kidney, so it's going to present as hematuria. And same is the case with lungs. If we have any kind of tumor, a big tumor have a lot of blood vessels, and a lot of blood vessels can sometimes rupture, which is basically going to present as blood. Is it clear? So in case of pulmonary system, if we have any kind of cancer, it would present as hemoptysis, right? Is it clear? Hello?
Yes, clear.
Okay, please respond. Okay. The next thing which you should keep in mind that if cancer develops, what are the predisposition factors to development of cancer? That's very important, right? So remember one thing. whenever we have a chronic irritant, right? So, for example, whenever we have a mucosal layer and we are continuously irritating it with certain irritants, so chronic irritation leads to cancer formation. That's really important. So, it's a generalized rule. You can apply it to anywhere inside your body. For example, if someone is having any, let's suppose, any squamous cell carcinoma of or esophagus, or he's having adenocarcinoma of esophagus, right? So for that, we required something, some irritant which should chronically irritate those mucosal surface, because chronic irritation is going to lead to formation of cancer, right? So for example, what can give us esophageal cancers? Do you guys have any idea, please?
GERD.
GERD, perfect. GERD. Okay. What else? Smoking can also give us cancer. It's a chronic irritant. But in case of lungs, the smoking is going to be the main factor which can cause irritation of your lungs epithelium, and it can lead to cancer, right? So whenever we have chronic irritation due to any kind of irritant, it would lead to cancer formation, right? One important thing which you should just keep in mind, and really high yield, you guys might have practiced one of you word MCQ related to that as well. Okay, so cigarette smoke comes on the first, right? So cigarette smoke, it's a normal practice, everywhere in the world, and it's a chronic phenomena. Like whenever someone is used to cigarette smoking, so he basically smokes for years. So it's a good irritant in order to cause a cancer, right? So smoking would just come on the first, right? And smoke itself has a lot of irritants, right? For example, polycyclic aromatic hydrocarbons, really high yield. Keep this in mind. You guys are going to be asked, on your U word in your NBMEs, they are going to ask you what is the main, you know, carcinogen, or what's the main component of the cigarette smoke, which basically leads to cancer formation. So you guys already know that cancer is basically a chronic irritation due to smoking, but specifically within the smoke we have polycyclic aromatic hydrocarbons, right? Arsenic as well can just cause cancer, right? So cancer is basically the smoking should just come first in your mind. What else? We have a gaseous thing known as radon. Do you guys know that? Hello?
Yes.
Yes.
How do we get radon? From uranium, right? Where do we
Radiation.
find uranium? We find uranium in soil. So you will, whenever you see certain scenario, right? We have okay. This is your exact scenario of your world as well, right? They are going to ask you. We have an individual. He lived at basements, right? His room was in the basement, simply, right? So he developed some lung symptoms, and in the end, they are going to ask you what's the main predisposition or predisposing factor which is causing cancer in that individual. So in closed spaces, for example, the basements, what happens? We have a lot of soil there, so the radioactive decay from the soil and the uranium component of the soil can give a radon gas, which is a colorless, you know, gas, and it can be a chronic irritant for your lung mucosa, and chronic irritant in turn can be your factor which predisposes or which causes cancer. Is it clear? That's really important to know. Okay, radon. Is it clear?
Yes.
Okay. Okay. As I already mentioned, for example, if we have chronic irritation, so obviously chronic irritation is going to cause cough as well, right? What else? What are the general symptoms of cancer? We are going to be having weight loss. Why are we going to have weight loss? Yes, there are the constitutional symptoms which are present, right? So whenever you see weight loss, okay,
Hmm.
and loss of appetite, so these two terms basically indicates more probably towards any kind of cancer, right? So these should be your points. Whenever you see we have an individual, he lost his appetite, he's having a weight loss with time. So the first thing which should just come in your mind that this individual must be having some kind of cancer, right? Because these are the symptoms which are basically associated with cancer. All of us know that, right? Hemoptysis, I discussed. Why are we going to have hemoptysis? Yes, because we have a cancer. Cancer cells itself need a lot of blood supply, right? And sometimes their blood vessels can rupture, and these ruptures of blood vessels can give you hemoptysis, right? And obstructive pneumonia. Okay, okay. There's just a post obstructive pneumonia. The concept is really clear. If you guys remember the concept of stasis, who is going to be giving me explanation of this point? Post obstructive pneumonia. Yes. Hello. Hello, are you guys able to hear me?
Yes.
Yes, please.
So where there is stasis, infection occurs there because there's no ventilation occurring at that point.
Perfect. So, whenever we have a kind of cancers, it would lead to stasis. And whenever we have stasis, that's a best medium for your bugs to grow. That's a best medium for your infection to occur. And you can apply this concept to any kind of stasis. If there is stasis in the heart, it would lead to endocarditis. If there is stasis in your kidneys, it would lead to UTIs. We already discussed these points, right? So post-obstructive pneumonia, whenever we have any kind of tumor, it's going to physically cause an obstruction there. If you have a physical obstruction, we have stasis. Stasis lead to infection. Infection, one of your infections is pneumonia, right? Okay. Okay. So there's a really interesting phenomena here. For example, if you are suspecting an individual of having any kind of cancer in his lungs, so what you are going to do? First thing to keep in mind, right? So we already know that the diagnosis for cancer is biopsy, right? But for example, if you have an individual in your clinic, right, you are doing some random kind of imaging, and in X-ray suddenly you find any kind of a lesion or a tumor. So what would be your next approach? Yes, anyone? Hello.
Can you repeat, please?
Okay, my question for you is, for example, if an individual just come for a normal follow up, right? For like you guys are going to be, residents once in, so if an individual come to you and you are just doing a normal imaging, and suddenly you just find any kind of tumor in his lungs, and it's just X-ray. So what would be your next approach? What do you think?
Biopsy?
Biopsy.
That okay, biopsy. Okay. Remember, what you would do first is that you should be, first of all, you should be thinking of whether it's a benign or it's a malignant. So for that, you should be telling this individual, do you have any prior imaging? Have you done any prior imaging? Okay, if he's saying yes, I have done. Okay, so first of all, you are going to compare the size of the tumor. Is it growing or not? Right? Because the first thing which would come in your mind is it a benign or malignant, right? Is it a less fatal or more fatal, right? Okay.
Yes.
Well, okay. If it's malignant, if it's more fatal, then you are going to diagnose it, and then you are going to go for biopsy. Okay. Okay. So we know that there are some primary tumors and some secondary tumors. What do you mean by primary tumor? If a tumor arises in the lung, that's your primary tumor. What's a secondary tumor? Secondary tumor
It's
basically come from metastasis, right? Okay.
yes.
Okay. So here you guys can see we have different lung carcinomas, right? We'll be discussing each one in detail. We have small cell lung carcinoma, we have non-small cell lung carcinoma. These are the two divisions. So what is small cell lung carcinoma? What is non-small cell lung carcinoma? That's really easy to remember. Small cells are very small, right? They are so small that you cannot surgically excise them. Is it clear? Small
Yes.
cells cannot be seen. If you can't see anything, you can't excise it, right? Okay. What is non-small cell lung carcinoma? It's big cancer. So if it's big cancer, you can excise it, right? You can do the surgical resection. Is it clear? So what is small cell lung carcinoma? Those cancers which cannot be surgically resected and treated with chemotherapy are your small cell lung carcinomas. Non-small cell lung carcinomas, those cancers which you can see and surgically resected, those are your non-small cell carcinoma. Okay. Let's discuss these carcinoma in a little bit detail. Okay. Do you guys have any questions till now?
No.
Okay. 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 If you guys have any question, you can just stop me. I'll just repeating that concept. Okay. Okay. Before starting the cancers, I need you guys to know one rule, right? Whatever cancer starts with letter S, just keep that in mind. What am I saying? Whatever cancer name start with S, it's going to be central and it's going to be present in the smokers. That's a general concept. Can you just please repeat what did I say?
Whichever cancer starts with the S,
Any
that's
cancer.
central and smoker.
Perfect. Okay, it's going to help you a lot. Okay. Okay. So let's discuss. Okay, we will be discussing TNM staging in the end, right? First of all, let's discuss each and every cancer, right? Small cell carcinoma. Okay, it start with S, right? So it is going to be present within the smokers and it is going to be centrally located near your hilum, right? Okay. Okay.
Yes.
Small cell carcinoma. Keep that in mind. You're going to be having some neuroendocrine cells present, right? So whenever we have neuro, as the name indicates, endocrine, it means certain hormones are going to be released from these cells. Am I right? Yes or no?
Yes.
Yes.
Okay, small cell lung carcinoma, we have discussed it a lot of time, if you guys remember, a lot of times in our endo, everywhere. Okay, but whenever we have any kind of endocrine problems, we just if it's related with any kind of cancer, the first thing which would just come in our mind is small cell lung carcinoma, ACTH. If you guys remember, Cushing ectopic ACTH. Remember small cell lung carcinoma? Did you guys remember that?
Yes.
Syndrome of inappropriate ADH. ADH, syndrome of inappropriate ADH, small cell lung carcinoma, remember? So they are neuroendocrine cells, okay, present in smokers and centrally located. If they are neuroendocrine cells, it means they are going to release certain hormones. What would be those hormones? Just keep that in mind. ADH, ACTH, what else? Eaton Lambert syndrome. What is Eaton Lambert syndrome? Can anyone just tell me? Or Lambert Eaton, you can say. Any idea?
It's a paraneoplastic syndrome.
Perfect. Okay, it's a paraneoplastic syndrome. Okay, let me just make it really simple. The antibodies are going to be against what?
The postsynaptic
Pre
choline receptor.
Calcium channel.
presynaptic calcium
Acetylcholine.
channels.
Calcium channel.
Calcium
Acetylcholine.
channels are
Yes,
blocked, and
calcium
because of
channel,
that,
yeah.
acetylcholine can
Okay,
be released.
against
Calcium.
calcium
Calcium.
channel. Okay, is it going
Calcium
to be a
channel, yeah.
presynaptic or postsynaptic channel?
It's postsynaptic. No,
Postsynaptic.
Postsynaptic.
presynaptic.
Pre-synaptic.
Presynaptic.
You guys are just
Pre-synaptic.
confusing it with another pathology. That's a kind of a little bit similar to it. Okay, what's the
Mm-hmm.
name of that? If we
Myasthenia
have antibodies
That
gravis.
against
myasthenia
myasthenia
gravis.
gravis,
Yeah.
perfect. Okay, so whenever you have Lambert-Eaton syndrome, it's associated with small cell lung carcinoma. Just think of this that those antibodies against calcium receptors are going to be coming from your small cell lung carcinoma cell. If you okay, my question for you guys, really important, really high yield, one of your NBA MCQ. We have an individual, he's having myasthenia gravis. What do you think? With which kind of cancer is it associated?
Thymoma.
Thymoma.
Yeah.
Thymoma.
Thymoma. Yeah.
Thymoma.
Chronic
Perfect.
hyperplasia.
Yeah.
Perfect.
Yeah.
Perfect. That's
Hypertension.
thymoma. Keep that in mind. Okay. So the first one was small cell lung carcinoma, right? So we discussed neuroendocrine cells. It starts with S. It's going to be present within the smokers, centrally located. Is it clear? The next one is going to be squamous cell carcinoma. Does it start with letter S?
Yes. Central.
What do you guys assume?
It
Central. It's
is
central.
central
It's central and it's going to be present in
smoking.
the
Smoker.
smokers. Perfect.
Smoking.
Squamous cell. Okay, normally where do we find squamous cells? You remember keratin, keratin, your skin, right? Your
Yes.
skin. Your skin have you a lot of squamous cells, right? So the skins and the keratins are really important. Just keep that in mind. Squamous cell keratin pulse. We are going to discuss in detail about the keratin, the outer layer, your dermis, your epidermis. We are going to discuss in detail. Okay, so remember these cells have intra, that's not intra, okay, just correct it. That's intercellular bridges, right? Between the cells, they have bridges, they have communications, right? So whenever you see keratin pulse in your, okay, how the keratin pulse are going to appear, right? Remember, it's going to be a kind of, you can just clearly distinguish that whenever you see a histopathological slide with a kind of keratin pearl, right? So you should, okay, let me just, okay, figure, they have already mentioned the figure. That is figure 9.20, okay? Where is 9.20? That's your 9.20. You guys can see, this is your keratin pearl, right? The spiral kind of pinkish material, which is, revolving around a center keratin pulse. Can you guys just see it?
Yes.
Yes.
Okay. So that's a
Yes.
keratin pulse. Whenever you see such kind of keratin pulse, the first thing, okay, and if you have any kind of history of weight loss, any history of cancers, the constitutional symptoms which we discussed, first thing which will just come in your mind is your squamous cell carcinoma. Is it clear? If it's lungs, we know the rule. It starts with S. If it starts with S, it's going to be present in the smokers.
Central.
It's going to be centrally located.
Central.
Okay, it's also going to, produce something. It's going to make something. What's that something? What's that hormone?
Parathyroid hormone.
Thyroid hormone.
Parathyroid hormone. Okay, if we have parathyroid hormone related peptide, what's the function of parathyroid hormone? Let's discuss that in as well because we know Indo. You are master of Indo. You all of you guys scored more than
Hypercalcemia.
90%.
That's lead to
Hypercalcemia,
hypercalcemia.
perfect. And how do parathyroid hormone make causes hypercalcemia? It's going to act in the kidney. Where exactly we know the renal system as well. Yes, two
Proximal.
locations in the kidney. Two. I need two locations.
Proximal.
Proximal convoluted tubule. Which enzyme is going to activate?
One alpha. One. 20.
One alpha
Is it
hydroxylase.
one?
Perfect. What else?
One alpha.
Where else? Whereas it would just act on your
Distal.
kidney. Distal convoluted tubule.
Distal.
Perfect.
Yeah.
That's perfect. Okay, what's the other function of PTH in your proximal convoluted tubule? Phosphate tracing hormone, right? It's a
It
phosphate tracing hormone, right?
decreases the reabsorption of the phosphate in the distal tubules.
Perfect. Decreases the reabsorption of phosphate in which tubule? Proximal or distal?
Proximal.
Distal tubule.
Proximal.
Distal
Proximal.
tubules. No.
Is it distal or is it
No, no,
proximal?
Distal.
it's proximal.
Distal is
Distal.
calcium.
Proximal.
Is calcium.
Phosphate and
Distal is
proximal.
Proximal.
calcium reabsorption.
Yeah.
In
Okay.
distal, it's
Distal
Okay,
is
calcium.
who should
calcium.
I believe? Okay, who should I believe? Because Dr. Abdurrauf is, an old student of ours, old is God. I would believe Dr. Abdurrauf. What do you guys say? Whatever he said, that is right. If you, even, your first set is wrong, everything is wrong. Dr. Abdurrauf is right. Okay, so PTH is going to act on proximal convoluted tubule, okay?
Yes. PCT.
Okay,
Yes.
so
Yes.
that's the thing. You should just keep in mind, okay? Let's discuss our next cancer, that is adenocarcinoma. Okay, whenever you see adenocarcinoma, what should just come in your mind? Let's just,
Glands.
remove this page.
Female
Glands, glands, right?
non-smoker.
Glands.
Yes.
Yes.
First of all, adeno, right?
Gene.
And whenever
Yeah.
you have adeno glands, mucin. Do you remember something? Mucin, right? Hello?
Yeah.
Mucin
Adeno are
production.
glands.
Gland.
Glands would make mucin. But
Yeah.
if you guys have
Mucin.
did your U world of cardiovascular U world, really thoroughly. So I'm going to ask you a question, and you guys are going to be answering me. Okay? Hello? Let's just test your knowledge as well. Okay? So shall I just go with that MCQ?
Yes.
Yes. Let's
Okay.
try.
We have an okay. We were having an individual. He was having adenocarcinoma, right? Suddenly he developed something called thrombophlebitis. Something
Okay.
he developed like thrombophlebitis and hypercoagulable state. You guys are going to name it. What's the name of this syndrome? Yes.
Please, can you repeat the question?
Okay, my question for you is, we have an individual, he was having adenocarcinoma. Is it clear? Hello?
Yes.
Okay. He developed migratory thrombophlebitis. What is thrombophlebitis? Simple. Let me just make it simple. Infection or inflammation of your superficial veins, right?
Yes.
Okay. Are you guys able?
Yes.
Are you guys getting the question?
Yes.
Okay.
Yes.
And
Yes.
after
Yes.
that, he was also having some hypercoagulable state. Hypercoagulable state. What's the name of this syndrome?
Rozo syndrome.
Browser syndrome.
Tozu syndrome, right?
Rozo
Tozu
syndrome.
syndrome.
Browser syndrome.
Perfect. Right? You guys have did your U world really great. Okay. Okay. So adenocarcinoma, the mucin, it's also going to release something called thromboplastin, right? We're going to discuss that in our hematology section. It's going to cause hypercoagulable state. That's going to activate your coagulation cascade, right? Just keep that in mind. So adenocarcinoma, does it start with the letter S?
No.
Okay, if it doesn't start with letter S, everything is going to be reversed. It's going to be peripherally present. Am I right?
Yes.
It's going to be more in non-smokers, right?
Yes.
Okay, male smokers, more like mostly the males are smoker or female? What do you guys think?
Female.
Females.
Female?
Male.
Okay.
Males.
Male, like
Female.
normally male, okay, males are smoker. So it's going to be, like, a kind of cancer seen in female smokers, right? If they are just, if they are smoking, they are often going to develop, adenocarcinoma, right? And it's going to be peripheral and nothing in the nodes on the comments. So you know the comments: Trozu syndrome, migratory thrombophlebitis, and hypercoagulable state. Mucin is going to be seen. Is it cleared? Yes or no?
Yes.
Hello.
Yes.
Okay, a large cell carcinoma. Okay, so still you have S in carcinoma, right? So it's going to be again present in smoker. Okay, it doesn't start with S. Okay, so for the large cell carcinoma, you should just think of, we are a little bit deviating from our generalized, thing which we made. As for smokers, it starts with S, right? So for the large cell carcinoma, it's going to be present within the smokers. It can be centrally or peripherally. But how to differentiate large cell carcinoma? That's really simple. If you do not find any neuroendocrine cells in a cancer, if you do not find any pearls, if you do not find any glands or mucin, what should be your diagnosis?
Large cell.
Large cells.
Large cells.
Perfect. That's so simple, right? So the above things, whenever they aren't present, it's going to be large cell carcinoma, right? And we have poor prognosis of large cell carcinoma. Keep that in mind, okay? The next one, which we are going to discuss, is bronchoalveolar carcinoma, right? So, do you guys know what is bronchoalveolar carcinoma? Mm-hmm. Yes, as the name indicates, bronchoalveolar carcinoma. That's so simple. The name is telling you everything.
It is the
Hello,
carcinoma with the best prognosis.
Adenocarcinoma.
adenocarcinoma.
You you can see bronchoalveolar carcinoma and adenocarcinoma, I think. Yep.
Mm-hmm. Okay. Yes. So basically, it's going to be a carcinoma present in your, mostly in the bronchioles and alveoli, bronchoalveolar, right? From pre-existing some colonal kind of cells, right? Okay. So it's not related with smoking. It do not start with S. It is going to be present peripherally, right? And it may present with pneumonia-like symptoms, right? So what do okay, Dr. Moaz already discussed these cancers, right? So it's a kind of overview for you guys. So what do you think? Okay, do you know the in pneumonia we are going to be having consolidation and everything, right? What would happen to okay in pneumonia if you are doing percussion? So would the sound be dull or no? What do you guys think?
Dullness.
Dull.
It's dull.
Dullness. Okay.
Yeah, because of the
Yes,
consolidation.
dullness.
Okay. Perfect. The next one is carcinoid tumor. So we are going to discuss carcinoid tumor, a lot. Believe me, in your GIT, we are going to discuss carcinoid tumor, and we are also going to discuss, something called carcinoid syndrome. Do you guys know what is carcinoid syndrome? Yes.
Yeah, it's a neuroendocrine tumor as well.
Okay. Carcinoid syndrome, not tumor. Hello, hello, hello. Carcinoid syndrome.
Patient present with flushing, diarrhea, and
Yeah,
wheezing.
they present with diarrhea, flushing.
Wheezing,
The one we
diarrhea,
studied in
flushing.
endocrine.
Okay.
Wheezing.
I think
Wheezing,
Mass of the
diarrhea, flushing.
neuroendocrine cells and chromogranin A positive.
Okay, chromogranin, as there are neuroendocrine cells, neuroendocrines are always chromogranin positive, right? But okay, you just told me about carcinoid syndrome. That's right. But here with me, you guys already know we are going to start from basics. What's the basic problem, or what is going to cause all of these symptoms? Serotonin, remember? Yes or no?
Yes.
Yes, the serotonin.
Yes, these tumors. Okay. So we'll be discussing in detail in our GI section carcinoid tumor, right? So carcinoid tumor basically is your small intestine tumor, right? So normally, whenever it is present in the small intestine, it won't cause any carcinoid syndrome. Why? Because once the serotonin travels into your liver is going to, it's going to simply detoxify it. Okay, we'll be discussing the pathway in detail, but for now, you should just keep in mind. You should let's make it simple. Okay, if you have a cancer, okay, not you. If someone is having cancer in the small intestine, carcinoid tumor, it basically present a polyp-like mass. So what would happen? All of the serotonin which your carcinoid tumor is dumping, it would just pass through the liver, and liver is going to eat it. It's going to detoxify it. No carcinoid syndrome. But if this tumor metastasizes into your liver, if it moves into your liver, and from the liver, if it's releasing serotonin, right? Are you guys able to understand what am I trying to say?
Yes,
Yeah.
sir.
Okay, if this cancer moves to the liver, and there if it's dumping of serotonin, so now you have no one to detoxify it. There is another thing in the lungs, it get detoxified. We are going to discuss that in detail. In that case, you are going to get carcinoid syndrome, right? So whenever the tumor is dumping off a lot of serotonin directly into the blood, then we are going to have carcinoid syndrome. Just keep that in mind, okay? So carcinoid tumor, it's a neuroendocrine tumor. It's going to release serotonin. Keep that in mind, okay? Not related with smoking, as it do not start with the letter S, right? So it can be central or peripheral, whatever isn't starting with S, we know it can be central or peripheral, okay? So it's going to be a polyp-like mass, low-grade malignancy can cause carcinoid syndrome. You guys know what is carcinoid syndrome. Sometimes it can dump off serotonin in the blood, and as the serotonin get in the blood, you are going to see the classic signs and symptoms of carcinoid syndrome, as you guys mentioned, diarrhea, flushing, and everything we are going to discuss in our GI section. Is it clear? Hello?
Yes, sir.
Yes.
So these were all of the tumors, the primary tumors. The secondary tumors, what are the secondary? Which just comes from other part and get into your liver. So from where can we get mostly the tumors into the lung? Yes,
From breast, colon,
breast, colon.
bladder, or prostate.
Adrenals.
Okay, adrenals. Okay, my question for you. Do the tumor comes from adrenal into the lungs or from the lungs into adrenal?
Lungs.
From the
From the
lungs to the
lungs.
adrenal.
From the lungs to adrenal. Keep that in mind. The most common site for the primary lung tumors to metastasize is your adrenals, right? Not from the adrenals into the lungs. So, okay, from the breast, they can come, from the colon, it can come, right? So keep that in mind. Are these cancers clear now? Yes or no?
Yes.
Yes, but
I
may I
believe you
clarify
want. Hello?
Dr. Amit, hello, Dr. Amit. I want to clarify. I'd like a clarification on something.
Yes,
So
please.
to clarify, you said that lung cell carcinoma could be central or peripheral. Is that correct?
Mhm.
And
Yes.
then you went ahead to say that bronchial carcinoid tumors can also be central or peripheral. Is that correct? I mean,
Okay,
the way
just
you
give me a sec. Okay, can you just please repeat your question because I'm getting some
So
calls?
you
Okay, what is?
you you did explain the first one, the large cells, and you
Mhm.
said it could be central or peripheral, right?
Yes.
And then
Mhm.
you also went ahead to talk about the carcinoid tumors can be central or peripheral. So
Okay.
are the carcinoid tumors also large cells or no?
Okay. No, they aren't large cell. They're a different kind of tumors, right? They're entirely different from your. For the large cell, what was the definition? If it do not have any endocrine cells, if it do not have any keratin pulse, then we are going to call it as large cell carcinoma, right? Carcinoid tumors are something which are different than large cell. They have neuroendocrine cells. They are going to release, serotonin. You guys know that, right? So these are different kind of cancers, right? Entirely different. Okay, but the nature you can say it can sometimes present centrally or periphery. You can just keep that in mind. And polyp-like mass. You know what is polyp-like mass? Kind of pedunculated mass, right?
So,
Okay.
gu- so guys, one thing for you. We call it as large cell
Okay.
adenocarcinoma because
Mm-hmm.
of the fact that so basically we so in tumors we have two things, right? So we have the differentiation and then we have the staging, right? So large cell so if a tumor is more differentiated, it's a very good thing, right? If a tumor is less differentiated, it's gonna be more malignant, it's gonna be more aggressive. Okay, so if a tumor is less differentiated, the cell is going to be very large, right? The cell becomes large, the cell becomes out of shape, right? So the reason we call large cell adenocarcinoma as large cell adenocarcinoma is the fact that that the cell is so de-differentiated, it's so undifferentiated that it's not resolving any kind of a cell right now, right? So like small cell lung cancer resembles rod cells. That's why we call it small cell lung cancer. Carcinoid tumor represents carcinoid cells. That's why we call it as a carcinoid tumor, right? Large cell adenocarcinoma does not like come near to any other kind of a cell, right? It does not come near to like neuroendocrine cells or carcinoid cells, and the cells are very large and abnormal looking, and that happens when the tumor has become very de-differentiated. There is no similarity to any kind of a cells, especially lung cells, and that tumor is going to be very 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 aggressive, right, and very malignant. So that is why we call it a large cell cancer, right? So you can see the same thing in other tumors as well. Whenever you go to other tumor, right, you can see that in other tumors as well. When you will do like what do you say, okay, so if you move to reproductive tumors, you're gonna see there is gonna be a large cell lymphoma of the testicles, right? So there is gonna be a testicular large cell lymphoma, right? So wherever you go, there is gonna be a large cell cancer, and the large cell cancer means that the cells have become very large and very de-differentiated, right? And they do not remember, then now they do not like mimic the normal cells anymore, right? Okay. Does that answer your question?
Thank you very much, Idris.
Thank you so much, Dr.
Appreciate it.
Moaz. Or thank you so much. Okay, Dr. Moaz is here. So we were doing a revision. So let Dr. Moaz just take the session further. Okay. Thank you so much. And Dr. Moaz is going to discuss, the lecture further. Dr. Moaz already discusses that. As I already mentioned, that whenever Dr. Moaz isn't able to attend, I'm going to do the revision, right? Okay. So Dr. Moaz today is going to continue the session. Thank you so much, Dr. Moaz, for being here, for helping the student. That was all for me. Thank you. And I'm also going to listen to Dr. Moaz lectures. Yes, Dr. Moaz, you can just continue, please.
Thank
Okay,
you.
just like okay. So do you guys want me to do the pathology, or we could even complete the pharmacology as well first and then move to the pathology portion?
We can already complete the ongoing pathology because he's actually doing a revision with us, and then you can now start pharmacology right after that. That's what I think.
Okay. Just give me a second. Hmm.
Hello.
Come in.
Doctor, we cannot hear you.
Okay. Hey guys, so we are gonna start the restrictive lung diseases first, right? So I told you about the obstructive lung diseases, right? So we were done with the obstructive lung diseases, but the restrictive lung diseases were left, right? So what are restrictive lung diseases, right? So basically, and these are your lungs, right? So we are gonna go to the basics of these things, right? So this is one lung, right? This is the other lung, right? Uh, so I got a little bit late. I just got free from the hospital and just calling from there, right? So if this is the lungs and these are the cavities, right? So what happens is that, so there are two parts of his lung like breathing, right? One is the inspiration and the other is the expiration, right? So whenever you are inspiring, right, the chest cavity is gonna expand, the lungs are gonna expand, right? These lungs expand, right? So this is important to know. Whenever you are inspiring, let me tell you again, whenever you are doing inspiration, right, lungs are gonna expand. Now, one lungs expand, more air is gonna get into the lungs, right? But in restrictive lung diseases, the main thing that is happening is that the lungs cannot expand anymore. Keep this thing in mind. In restrictive lung diseases, the lungs will not expand anymore. Whatever you do, right, the lungs will not expand now. So this is important for restrictive lung diseases, right? So now there could be two reasons that the lungs can't expand, right? So keep that in mind. So there are two reasons the lungs cannot expand, right? Or we call it as two types of restrictive lung diseases. The number one type is that the muscles, so like whenever we inspire, the diaphragm is gonna contract, right? The accessory muscles are gonna contract, right? So diaphragm contracts. If diaphragm is like this, it's gonna contract, it's gonna become like this. Okay, this is how it's gonna happen. But what if I say that the diaphragm is very weak now? What could be the reasons the diaphragm could be weak? Then the most important reason is amyotrophic lateral sclerosis, right? We call it as ALS or amyotrophic lateral sclerosis, right? Amyotrophic lateral sclerosis is a very, very important cause of diaphragm weakness. Okay. Now, in amyotrophic lateral sclerosis, the diaphragm is going to get weakened, right? Do you want me to go into detail of ALS, right? Because we are going to do it in detail in neuro as well.
Yes, please.
Okay,
Thank
so basically, what is amyotrophic lateral sclerosis? So we have two types of motor neurons, upper motor neurons and lower motor neurons. Not gonna go into the detail of that right now, right? Because we have a separate physiology lecture of that in neuro. But we have two types of motor neurons, upper motor neurons and lower motor neurons. Normally, lower motor neurons or upper motor neurons are damaged. Sometimes one is damaged. But in amyotrophic lateral sclerosis, there is an autoimmune problem and both the upper and lower motor neuron get damaged. Okay. Both the upper and lower motor neurons are gonna get damaged at the same time, and it's gonna cause a lot of damage to the to the nerves, right? Then you're gonna have fasciculations, you're gonna have muscle weakness, you're gonna have muscle tightness, right? So basically, this happens in all patients. So they are gonna give you a patient. They are gonna say that a 70-year-old male comes to you and this male is having fasciculations, right? This male is having weight loss, right? Since this male cannot speak properly, the tongue is atrophied, there is dysphagia, right? There is limb weakness as well, right? All of these things are going to present, right? But the most important least side effect of amyotrophic lateral sclerosis is that you need to keep in mind is these patients die of respiratory problems, not anything else, right? Because the nerves get so weak that the diaphragm cannot contract anymore. Okay. Similarly, in polio, right? If the diaphragm is affected, you're gonna get weakness, right? In myasthenia gravis, right? If you're having myasthenia gravis or MG, right? So in myasthenia gravis, again, you're gonna get weakness. We have discussed in detail what is myasthenia gravis. So later in the evening, right, when the muscles are gonna be weak, you are gonna have problems respirating, and you are gonna have a restrictive lung disease, right? So keep these things in your mind, right? Keep these things in your mind. How do these things cause problem? Okay. How do these muscular weaknesses are gonna cause you problem? They're gonna cause you respiratory problems. Okay. Now you can have another thing as well, right? So if this is the lungs, right, and these are the chest wall, sometimes the chest wall is gonna become so stiffened that even if the chest expands, right, the muscles along with them, like the lungs cannot, if the lungs expand, the chest wall cannot accommodate them because they are like staying at the same place. Are you getting my point?
Yes.
Yep. So basically, chest a lung is captured in a chest wall, right? So if the chest wall does not expand, the lungs cannot expand, right? So if a patient is severely obese, right? They love this question. NBMEs love this question. If a patient is severely obese, and the most important it is if a patient is having AS. This is an important question. Please, please, please keep this in mind, right? So keep these things. Ankylosing spondylitis in your mind, guys. Right? Please keep ankylosing spondylitis in your minds. So what is ankylosing spondylitis? So okay, so yeah, I haven't done ankylosing spondylitis right now, but this is how they link things. This is one of the most beautiful concepts that they like to link, right? So basically, um, okay. So do you guys know about ankylosing spondylitis? Let me. Okay, so basically, what ankylosing spondylitis means is that in ankylosing spondylitis, right? If you have a spine, right? If this is your spine, right? If this is your spine, yeah, this is your spine, right? What happens is that there is going to be the inflammation of your spine, right? There's going to be inflammation of your spine, right? And whenever there's an inflammation of any bone in the body, we call it as inflammatory arthritis, right? This is important, right? Because a lot of questions are going to come on this, right? Ankylosing spondylitis is the most favorite, like favorite tested topics of NBMEs and USMLEs, right? They love ankylosing spondylitis, right? So basically, what is going to happen is that there is going to be the inflammations of spine, right? And whenever there is going to be inflammation of the spines, right, there is going to be fluid that forms here, right? Whenever there is inflammation, there is going to be edema, right? So there is going to be edema that is going to be present here. And it's going to be inflammation, especially in the lower back. It's going to happen, right? Now, the person is going to complain to you that whenever I wake up from sleep, I am having a lot of pain and stiffness in my lower back. And why is the pain present there? The pain is present there because the stiffness is present there because there is a lot of edema that is present in the lower back due to the fact that there is inflammation. Okay, telling you again, due to stiffness, there is going to be a lot of lower back edema, right? A lot of lower back edema is going to be present, right? And when that lower back edema is going to be present, the patient is going to have a lot of stiffness in the back, right? Now, the interesting thing that is present here is then the patient is going to say, whenever I start walking, doctor, right? Whenever I start walking, right? After 30 or 40 minutes, I feel better, right? Why are you going to feel better after 40 or 30 minutes? Because the inflammation is now going to resolve away when you start walking or start exercising. Okay, and you're going to feel a lot better. Now you're going to feel a lot better. So basically, the question they give you, they can say that a 30-year-old, so it is common in males, and especially say between the ages of 25 or 50, 40. They're going to say that a 40-year-old, 35-year-old male comes to you, right? And that male is having stiffness in the back, right? The patient's back is very stiff. The patient is having a lot of stiffness in the back whenever the patient wakes up. And if a patient does 20 or 30 minutes of like walking or anything with this back, the patient starts feeling very better, right? The patient start feeling very better as soon as the patient does all of these things, right? So now the important thing that I am discussing here is that this is important, right? So if this is the spine, the ribs are attached to it as well, right? The ribs are attached to, and this is the concept that a lot of people don't understand, right? The ribs are attached to it as well, right? So what happens, and whenever you inspire, these ribs are gonna move outwards, right, in a bucket and handle pattern too. So like to accommodate the expanding lungs. But in ankylosing spondylitis, these ribs are gonna get inflamed as well. And when these ribs get inflamed, you're going to get a restricted lung disease. Now, they want to know how does a patient get restricted lung disease in ankylosing spondylitis, right? They love to test this concept again and again. Why is a patient with lower back pain in the morning having dyspnea all of a sudden, right? What is the mechanism of this thing to happen, right? And then they're going to ask you the FEV1 values as well, FEV1, FVC values. We're going to go into the detail of this later, right? Yes, exactly. So scoliosis or kyphoscoliosis, especially scoliosis, in which there is a lateral curvature, it's gonna cause the same thing as well, right? It's gonna cause the same thing as well, right? It's gonna lead to destructive lung diseases as well, right? So if I repeat ankylosing spondylitis, there is gonna be back pain before the age of 45. The back pain is gonna be present in the morning, and there is going to be stiffness in the morning that we call as morning stiffness, and that improves with activity, right? And spinal mobility is going to be very reduced, right? Spinal mobility is going to be very reduced, and then you are going to have dyspnea as well. And there are other things that can happen as well, but these are the main important things that you should keep in your mind, right? Okay, any questions till now, guys? I don't. So basically, if you go into the first aid, there is only three lines, two lines written about it. Right. But you have to go into the details of these things. Right? You have to go into the details of these things. Okay. Now, basically, so we have done into this thing that lungs cannot expand, right? So what does that means physiologically, right? So what if I give you a question, pet question of restrictive lung disease, and then I will ask you what pathophysiological or what physiological parameter is going to be disturbed in a patient who is having a restrictive lung disease. Anyone? Anyone? Which physiological?
Force vital capacity and total lung
Okay, and any, so like, okay, but what's the reason that the lungs cannot expand? What's the reason? So basically, this is the reason. So we call it as a lung compliance, right? We have already discussed lung compliance before, right? Keep this in mind, right? So lung compliance is the thing. So lung compliance means that your the force needed to expand your lungs, the pressure needed to expand your lungs, right? And whenever a patient is having a restrictive lung disease, you're gonna need increased amount of pressure or force to expand the lungs now, right? Again, if a patient is having restrictive lung disease, you're gonna need increased amount of pressure or force to expand the lungs. This is important regarding restrictive lung diseases. Okay, is that clear, guys? Now,
Can you
what?
please repeat
Okay.
that lung compliance?
Okay, so basically, what is compliance? Let me first tell you what is compliance. So, compliance basically means how compliant or flexible a thing is, right? How compliant or flexible a thing is, right? So, basically, if you are pumping like air into a balloon, if the balloon expands very quickly, the compliance is going to be high. If the balloon does not expand quickly, then the compliance is going to be low. Now, there are a number of reasons why compliance could be low, right? So in there we are discussing those, right? So basically in restrictive lung diseases the lung compliance is very low. What does that means? It means that lung is very stiff now, right? Lung is very stiff now, right? And if you put enough pressure or force into the lungs, nothing is gonna happen still, right? Still nothing is gonna happen, right? Think of lung as a balloon, right? If a balloon is easy to blow up, it means it is stretchy. That is high compliance. If a balloon is hard to blow up, it means it's stiff. That is low compliance, right? So now imagine your lungs are a balloon. Lung compliance means how stretchy your lungs are when you try to breathe in. If your lungs stretch easily when you breathe in, they have high compliance, right? If your lungs are stiff and hard to fill with air, they have low compliance, right? So if you have pulmonary fibrosis, a condition in which there is going to be scars in the lungs, the stretchy lungs are going to be replaced with solid structures, right? So let me ask you, if I add glue on your balloon, right? If I add glue on your balloon, or if I add like steel on your balloon, is the balloon going to expand more quickly now or less quickly?
Less quickly.
Yes, quickly. So this is what are the restrictive lung diseases are, right? These are all the restrictive lung diseases. And then if I ask you, right, that we have put the balloon in a cage, right? We have put a balloon in a cage, right? And the cage is very small, and the cage it's just gonna stay in its place, right? If you try to expand the balloon, will the balloon expand now or not?
No.
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 So basically, this is the these are the restrictive lung diseases, right? So whenever that there is chest wall abnormalities, right, there is obesity, right? So when a patient is very obese, there's going to be a lot of fat around the chest wall. The chest wall is not going to expand properly. The lungs are going to expand properly. Similarly, in scoliosis, right, the chest wall is going to be disturbed, and the chest wall won't expand properly again, right? So these are some problems. Right now, there are some other problems as well, which are known as the intrinsic problems. So intrinsic problems means that the problem is present inside the lung, and it's not present outside of the lungs, right? So what are those intrinsic problems, right? What are the intrinsic problems that is going to cause these things, right? So we are going to go into the detail of each of these now, one by one, right? But first, one thing that is important, right? When the lungs cannot expand, all the lung volumes are going to be reduced, right? FVC is going to be reduced, right? ELC is going to be reduced. Okay, keep that in mind, right? So FVC and TLC are going to be reduced, and you're going to notice it. And they're going to ask about this in your questions as well, right? Okay, okay, let's start now. So the number one disease that we are going to do today is this was just an intro, basic like introduction. So the number one thing that we are going to do today is IPF, which stands for idiopathic. It stands for idiopathic pulmonary fibrosis. Okay. So what is idiopathic pulmonary fibrosis? As the name says, it is a fibrosis of the lung. Right? The lung is gonna get fibrosed, right? The lung is gonna get fibrosed, and you're not gonna have any reason why does the lung gets fibrosed. You're not gonna get any reasons, right? So basically, in this thing, there's gonna be cycles. So first of all of a sudden, the lung is gonna get injured, right? You don't know how, right? The lung is gonna get injured, right? And whenever any body part gets injured, right, there is going to be inflammation there, right? And inflammation is going to be followed by repair, right? And in repair you are going to get scars, fibrosis, right? So basically this is going to happen again and again and again and again. This is associated with smoking, right? So what is eventually going to happen is that the lung is going to be completely replaced with fibers, right? Lung is a stretchy material, right? Lungs are very stretchy, right? But if you smoke, right, if you do a lot of smoking, eventually what is going to happen is that the lungs is going to get so much damage, right? The lung is going to get so much damage, right? And that the patient cannot, the pulmonary function is going to be impaired, right? The pulmonary function is going to get impaired, right? Is that clear, guys? Now, if a patient
Yes.
has idiopathic pulmonary fibrosis, the patient is going to die very soon, right? The patient is going to die very, 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 very soon, right? Now, what are the features that you're going to have this in restrictive lung diseases? We did not clear that, right? First of all, the patient is going to say, I am having dyspnea, right? This is the first thing. The patient is going to have dyspnea, right? Especially in idiopathic pulmonary fibrosis. Now you would say, Dr. Mohas, dyspnea is present in almost all of the other problems. So how is this thing important, right? So in dyspnea, apart from dyspnea, you're gonna have cough, and the cough is gonna be non-productive. Remember, it's a non-productive cough, right? The cough in bronchitis was productive. The cough here is non-productive. The cough in bronchitis was productive. Okay? This is the second difference because we are going to differentiate it for the emphysema and pneumonia, right? In pneumonia, there is going to be fever. No fever is going to be present here. Okay. Similarly, you're going to have bibasilar. See, now you're going to have bibasilar inspiratory crackles as well. Okay. So you're going to have inspiratory crackles as well, which is not going to be present in like pneumonia. Okay, so these three things are gonna differentiate it from emphysema, from asthma, from every other thing, right? Mm. Okay, so how to differentiate from cystic fibrosis, right? Cystic fibrosis is very different from idiopathic pulmonary fibrosis, right? Okay, so have you guys done cystic fibrosis with Dr. Hammond?
Yes.
Okay, so basically, uh,
No, we've not.
so,
With Dr. Ahmed, cystic fibrosis, no.
okay, but have you done bronchiectasis with him?
No.
Yes.
Okay, okay,
Bronchos we have done.
okay. So let me tell you one thing. Idiopathic pulmonary fibrosis, first thing, always look at the epidemiology. IPF is a condition present in more than 50 years of age, right? Cystic fibrosis is going to be present at 2 years of age. Big difference, right? There's going to be a child or a baby that is going to present with child or cystic fibrosis, or then that baby may be in 10 to 15 years, right? And if it does not get treated, the patient is going to die in like 4 or 5 years, right? Second thing is that, right, in case of cystic fibrosis, you're going to have recurrent infections, right? There are going to be recurrent infections of the lungs, right? And in infections, there is fever, there is pain, right? And the patient is going to have wheezing as well, right? This is a characteristic feature of obstructive lung diseases. The wheezing is a characteristic feature of obstructive lung diseases. In restrictive lung diseases, you are going to have crackles and dry cough, right? In cystic fibrosis, you are going to have wet cough, right? Or productive cough, right? In cystic fibrosis, you are going to have weight loss, you are going to have infertility, you are going to have meconium, all of those things are going to be ready. All of these things are going to be present, right? Again, the sputum in cystic fibrosis is going to be thick and purulent. It's going to be smelly. It's going to have blood as well. The sputum is not going to be present in idiopathic pulmonary fibrosis, right? Any other thing? Any other thing that you want me to clear?
Doctor, may I ask a question?
Yep. Yeah.
You say in cystic fibrosis will have blood in the sputum. Why is that?
Okay. So basically, cystic fibrosis causes repeated infections, right? Right. So cystic fibrosis will cause repeated infections, right? So when basically, if these are your airways, right? If these are your, so if this is the airway and this is the lung, right? And all of these airways are coming out of lungs, right? Uh, what is going to happen in this case is that if there is a lot of infections here, right? There's going to be a lot of inflammation as well, right? A lot of inflammation is going to happen there as well. Ultimately, what is going to happen is that these bronchi are going to get dilated, right? If these are this size, they're going to get this size big, right? This is known as bronchiectasis, right? So bronchiectasis is a condition in which there is persistent inflammation of the bronchial walls. These walls are going to get inflamed at every time, right? Because there's going to be, whenever there's going to be an infection, neutrophils, macrophages are going to come here. They are going to release enzymes. These enzymes are going to damage the airway tissues, right? The airway is going to get permanently dilated, and then it's going to get structurally weakened as well, right? Now, if this is the air blood vessel, this is the airway. Beneath the airway, we have blood vessels, right? But normally, these blood vessels are protected by these things, by the airways, right? They are always protected by the airways. Again, keep this thing in mind, right? They're always protected by the airways. But if the airways are very damaged and they're very weak, guess what? What is going to be exposed now? Anyone?
The blood vessels.
Yeah, so the blood vessels are going to be exposed. This is one thing. The number one, two thing, when we do pathology, like general pathology with you, we are going to go into inflammation. And what happens when a portion of a body is inflamed, right? Does the blood supply increases there or it decreases?
It decreases.
No, so it
Increase.
increases. So it's gonna increase.
Increases.
It will
Yeah.
increase.
So whenever you're getting inflammation or whenever you're getting any kind of a trauma in the body, right? The first thing that is happening is the blood vessels are gonna dilate there, right? Why are they gonna dilate? They just imagine if you have an accident at a highway, if someone has an accident at a highway, right? All of the police is gonna go near the accident, right? So neutrophils and macrophages are the police, right? So whenever you are having any inflammation, you need your police to be present at the side of the inflammation, right? Similarly, in case of any inflammation in the body, the police or the blood vessels are the police, that is neutrophil and macrophages, are going to go there, and the blood vessels are going to get dilated, right? They're going to get bigger. They are going to ask the body to give space to the neutrophils, right? So the blood vessels here are going to get dilated, right? They're going to increase the blood supply. They are going to get dilated. They are going to get tortuous, right? And they are going to get fragile as well. When there is a lot of blood that is going through the blood vessels, they are going to get dilated and, right, tortuous, right? Second thing is that in cystic fibrosis, a lot of bacteria are going to sit here. These bacteria are going to erode the vessel walls, and then they are going to trigger bleeding, right? This is one thing. Second thing, and which the last thing that is important here, is the fact that when you're going to have so much infections, right, what other thing are you going to have, right? You're going to have sputum, right? You're going to mucus production, you're going to have sputum production, right? And this area is going to be filled with mucus, and this is, so basically bronchiectasis is an obstructive disease. Remember what did I tell you guys in obstructive diseases or the physiology of bronchiectasis? Anyone?
That the air was not getting out in the
Yes.
obstructive
Why
disease
was they not getting out?
because there
It
was
was trapped.
Yes,
it
so
was
it was trapped. So in
blockage.
bronchiectasis, it gets trapped as well. Here, mucus is gonna sit. This thick mucus won't let the air go out. That is why bronchiectasis is a obstructive lung disease. So now, what did I tell you? When the air was trapped, do we blow more forcefully or in expiration or less forcefully now? So basically, we
More
are gonna more forcefully,
Yeah.
right? So we are gonna try to cuff with as much force as possible. And whenever we are gonna do that, again, the vessel walls are weak, right? We are gonna get bleeding. So basically, that's the concept behind bronchiectasis and bleeding or hemoptysis. And that is why whenever we have bronchiectasis, we are gonna have spurt blood in our cuff as well. Yes, Dr. Aksa.
Okay, so it might be a stupid question, but so in restrictive lung diseases, whenever there's repeated inflammation, there's going to be fibrosis,
Yes.
and it's going to lead to narrowing of the airway, right?
Uh, kind of, yes.
Okay, so in bronchiectasis, the same inflammation is leading to dilated airways. How is that?
Okay, so that's not a good a stupid question. That's a very good question, right? Like they like the question. So let me tell you how is this thing happening. Right? So let me tell you this. If this is the lung, right? Introvert. Okay. If this is a lung, right? So lung has two parts, right? Let me tell you. One part is the airways, right? The other part is the parenchyma of the lungs, right? So, in order to in order to make it more clear with you, right? So, basically, what is happening is that basically, lung is like a jelly, right? We have a jello, right? We made a jelly, right? So, all of this was a jelly, right? And in jelly, now we have put like four or five, uh, four or five like steel rods or anything like that, right? So, these rods are the airways, right? Okay. I hope you're getting my point, right? So the lung is a jelly, and this jelly is known as the parenchyma of the lung, right? This whole thing is known as the parenchyma of the lung, right? This is the lung parenchyma, right? And in the lungs, then we have airways as well, right? Let me show you a lung morphology picture. Good question. Okay. So guys, if you look here, these are our lungs. So if you see, we have two parts in our lungs, right? One is this part, right? And the other are these airways, right? Okay. Okay. So what is happening in case of idiopathic pulmonary fibrosis or any restricted lung disease is that this part is getting damaged, right? This part is getting inflamed, right? This part, okay? All of this inner part, right? And when this part is getting fibrosed, like, right? Whenever this part is getting fibrosed, right? It's gonna put pressure on the airways and it's gonna like cause the airways to like collapse, right? It's gonna cause the airways to collapse. So like again, just think of a balloon, right? If you're having a balloon, right? What if I say to you, I have put water outside of the balloon everywhere? Will the balloon get smaller or bigger? Anyone?
Small.
Smaller, right? Smaller. So this is what is happening in case of idiopathic pulmonary fibrosis, right? The airways are not getting inflamed here, right? The scarring is happening outside the airways in the lung parenchyma. That is why we call it as a parenchymal lung disease or interstitial lung disease. So interstitium means, so whenever you hear the word interstitium, it means the space that it outsides the body tubes or body linings, right? So interstitial space of tissues is the space that is present outside the blood vessels, right? So basically, in restrictive lung diseases, right? Again, so you can see all of this is the interstitium, right? This is gonna get damaged, right? So what is happening is that you're gonna get scarring outside of the like vessels, right? And then it's gonna get smaller, right? But in case of bronchiectasis, right? Everything is gonna happen inside, right? So now if I say all of this water is coming inside, now will the balloon expand or not?
Expand.
Yeah. So if this is an airway, this is a very simple airway, guys, right? Right. If I put steel rods outside of it, right, it's gonna get smaller, right? This is what is happening in idiopathic pulmonary fibrosis. This thing is gonna collapse, right? What if I put the same scars inside here? Now the airway won't get closed. It won't get closed. It's gonna get dilated. It's gonna stay the airway, it's gonna cause the airway to stay open. So basically this is how like in idiopathic pulmonary fibrosis the lungs are gonna get shut, right? Whereas in case of like bronchiectasis the lungs are gonna stay very dilated, right? Okay. So basically that was idiopathic pulmonary fibrosis, right? It's related to smoking. There is gonna be dyspnea, right? There is gonna be non-productive cough. There is gonna be crackles, right? And there is gonna be fatigue as well, right? There's gonna be fatigue as well, right? Okay. Is that clear, guys?
Yes, good.
Okay. Okay. So let's go forward then, right? Now let's move forward, right? Okay, so the next thing that is important is the CT of it, this thing, CT of IPF. I want you to guys look at this very closely, right? So this is a characteristic features of idiopathic pulmonary fibrosis, right? What is happening here is you can see that there is honeycombing, right? Have you seen a honey nest? Like, let me show you a honey nest. Okay, so okay, this one. This is a honey nest picture, right? Please keep this in mind. This is a picture of honey nest. Again, this is a picture of honey nest. And if you see here, the same thing is present here. It's like a honey nest. Okay. So is again, this is like a honey nest appearance, right? So whenever you get this appearance and there is gonna be like honey nested pattern, right? Then you're gonna know that this patient is having bronchiectasis. Say the follows. Okay. Okay. So you can see here, right? That there are small dots. There are very small dots that are present here, like round polygonal dots that are present here. Okay, these are also known as like hmm, these are known as the honeycombing, and this is going to happen in the CT scan of pulmonary fibrosis, idiopathic pulmonary fibrosis. It's that, is that real?
I do have a question. The honeycombing, do we see it in more than one pathology? Because I feel like in some of the questions that were for restrictive pathologies, they were saying honeycombing as well.
Yeah, so you're gonna see it in other pathologies as well, right? But the most important one that it that with which it is associated is gonna be like um, idiopathic pulmonary fibrosis. But yes, it's gonna be present in other ways as well. It's gonna be present in asbestosis as well. It's gonna be present in systemic sclerosis, lung diseases as well. It's gonna be present in sarcoidosis as well. But in the end, right? So more normal in restrictive lung diseases, but towards the end, right? Now, one other thing that is very important. We have type 1 pneumos. We have two types of pneumocite. I don't know if we did it or not. Right? So this is not the only problem that is going to happen. Then we have type 1 pneumocytes. We have type 2 pneumocytes as well, right? So what are type 1 pneumocytes? So type 1 pneumocytes are the pneumocytes or lung cells that help us in gas exchange, right? Type 1 pneumocytes, right? Type 2 pneumocytes perform other function that is related to repair, right? Now, if the lung is completely getting damaged for the past 2 or 3 years or past 4 years, right? The lung is gonna say, just skip the type 1 pneumocytes. We don't need gas exchange as much, and we are gonna need more repair. And for more repair, the body is going to increase type 1 pneumocytes, the body is going to increase fibroblast as well, right? So you're going to have increased amount of fibroblast for fiber formation, and type 2 pneumocytes and type 1 pneumocytes are going to be reduced. And when type 1 pneumocytes are going to be reduced, what is going to happen eventually? The thing that is going to happen eventually is, right, the blood gas exchange is going to be less as well. So there are going to be two reasons for low gas exchange. One is going to be the fact that less air is coming in, right? One is the fact that less air is coming in, and second is the fact that the air that is coming, so obviously less air is coming in, but at the same time, the air that's coming, right, it's not gonna get diffused, it's not gonna get exchanged, right? Why? Because we need type 1 pneumocytes for gas exchange, and those type 1 pneumocytes are unfortunately not present. Okay, any questions till now? I think we are clear, we are done with like idiopathic pulmonary fibrosis. Now, okay, now let's move to the next disease, right? So the next disease is hypersensitivity pneumonitis, right? So what is hypersensitivity pneumonitis, right? Hypersensitivity pneumonitis means that sometimes you can have environmental allergens such as pollen, right, or aspergillus. Especially in farmers, you're gonna see this thing, right? Which when inflamed, right, when you're exposed to those things, right, you're gonna get a fever, right? So they are gonna give you a patient which is gonna be exactly like a patient of idiopathic pulmonary fibrosis, but with fever and episodic. So episodic fever, cough, dyspnea, right? And so this is how and crackles, right? This is self-limiting, right? But if it happens for a long time, there's gonna be fibrosis, right? And again, there's gonna be fibrosis, and after some time, there is gonna be honeycombing as well, and this thing as well, right? So how is hypersensitivity pneumonitis gonna present to you, right? Let me give you some case scenario for it. Okay, so in case of, so basically they're gonna say that a 55-year-old farmer presents to the general practitioner with a 3-month history of like progressive dry cough, exertional dyspnea, fatigue, and low-grade fevers. He says he is having no chest pain or no hemoptysis. So why is hemoptysis is important? Because it's not bronchiectasis, right? Okay. He lives in a rural area and he works as a bed breeder, keeping more than 50 pigeons. He's a known smoker. Why is known smoker important? Because if he was a smoker, then maybe we could have thought of pulmonary idiopathic pulmonary fibrosis, right? And the patient is having respiratory crackles as well. Chest X-ray shows reticulonodular opacities or honeycombing, right? So the other name of honeycombing is reticulonodular opacities, right? right? There is ground glass opacity, centronodular nodules, and honeycombing in lower lobes. Which of the following is the most likely diagnosis? And then they're going to say idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, sarcoidosis, no chronic bronchitis as well. So this is how you're going to differentiate, guys, between all of these things. Okay. So this was hypersensitivity pneumonitis for you. Have you done sarcoidosis? My mind is saying yes. I don't know for sure.
No, we haven't.
Okay. Now comes the most important disease of your USMLE, right? It's the most important disease of your USMLE. Everywhere you go, you're gonna see sarcoidosis, right? So what is sarcoidosis? Sarcoidosis is an immune problem, right? Here, granulomas are gonna form whole throughout the body, especially non-gastritic granulomas, right, in the lungs, right? Okay. So you're gonna get non-gastritic granulomas, and that non-gastritic granulomas is gonna be present throughout the lungs, especially in the lungs, lymph nodes, and in the body as well, right? So then, how is this thing gonna present, right? There's gonna be immune-mediated non-gastritic granulomas, right? And then the patient is gonna present with some very common features. And what are those features? First of all, the patient is gonna have cough. The patient is gonna present with cough. The patient is going to have hypercalcemia as well, right? This is very important. So if a patient comes with cough, hypercalcemia, and crackles, right, then you're going to say that this patient is having sarcoidosis. Okay, cough, hypercalcemia, and crackles. This is the deadly combination for sarcoidosis, right? Now we are going to go into the details of a lot of these things, right? So whenever you're going to see sarcoidosis, you can do a serum ACE levels. So you can do check serum ACE levels, and these ACE levels are going to be increased a lot, right? And then you're going to see CD4 to CD8 ratio in bronchoalveolar lavage, and that is going to be increased as well, right? This is again common in females, especially in African American or black females, right? This is usually asymptomatic. Right? The main imaging finding that you're gonna see in sarcoidosis is hilar. I'm gonna go into the detail of hilar right now, right? But remember, it's gonna sarcoidosis usually causes a lot of other problems. It's not just a single system disease. It's not just gonna remain exclusive to the lungs, right? So first of all, it can cause facial nerve palsy, right? So if a person with hypercalcemia, facial nerve palsy, and cough comes to you, bam, sarcoidosis, right? So there's a mnemonic sarcoids. Let's go over this mnemonic. So first of all, S stands for common and asteroids bodies. So these are the bodies that you're gonna see in the histology, right? The Shaman and asteroid bodies are the bodies that you're gonna see in the pathology of these first patients, right? Common and asteroids bodies, right? And then you're gonna have rheumatoid arthritis like arthropathy. So sometimes they're gonna be there's gonna be like pain in the body as well in case of in case of this. C stands for calcium. O stands for ocular uveitis. It's gonna cause eye pain as well, eye problems as well, right? I stands for increased fibrosis, right? Basically, and S stands for skin changes. So there's gonna be lupus pernio. We are gonna go into the detail of that now. Okay, is that clear, guys? Me, let me pull up the pictures of lupus pernio. So, so one important thing that the patient of sarcoidosis have is erythema nodosum, right? What is erythema nodosum? Erythema nodosum are tiny tender nodular bumps that are present inside in front of the shins, right? So in front, so the question is going to say that the patient is having pain. So patient is having cough, hypercalcemia, right? And then there is tiny tender nodules that are present in front of the lower legs or shins, right? There are going to be tiny tender nodules in front of the legs or lower shins that are present, right? And these are going to be like erythema nodosum, right? And then there is going to be skin changes around the cheeks, which is going to be known as lupus pernio, right? So whenever a patient with erythema nodosum and cough comes to you, please, please, please think of sarcoidosis for 1 second, right? Now, remember one thing, the granulomas sarcoidosis causes chronic cough. So two more common causes of chronic cough is one sarcoidosis, the other is TB. So you're gonna see in diagnostic steps in TB is that in TB you are getting caseating granulomas. So you're gonna get caseating granulomas in case of TB, whereas in case of sarcoidosis you are gonna get non-caseating granulomas. Keep this thing in mind. Right? Now, if you look at the X-ray, right? If you look at an X-ray, you're gonna see this is the hilum of the lung, and there are a lot of lymph nodes that give it a black area. But if there is hilar adenopathy or the hilar lymph nodes are destroyed, then this white area, this blackish area is gonna get converted into white. Whenever you see this white area, sometimes they're gonna just give you a cough, and then they're gonna give you this X-ray, and they are gonna ask you what is the most likely diagnosis, right? So in this case, the most likely diagnosis is gonna be sarcoidosis. You're gonna have to look at the hilar adenopathy, right? Again, hilar adenopathy has increased a lot. You can see, right? Okay. So basically, this was all from sarcoidosis for you guys. I think that's enough for sarcoidosis. Any questions regarding sarcoidosis? Any questions, guys?
No.
Okay.
No questions, but I wanted to ask a question. I don't know how that question would sound, but you said it in passing that for TB you always have chronic cough. Yes, I know that. But do you always have chronic cough in pulmonary tuberculosis?
In sarcoidosis or TB?
No. In TB. I know you said it in passing, not like you were talking about TB, but do you always have cough? Does the patient always present with cough for pulmonary tuberculosis? Or are there cases where you can have the patient present with other things like fever, night sweat without cough? And then you still make a diagnosis of pulmonary tuberculosis.
Okay, so yeah, depends, right? Most likely the patient. So right, so depends. The patient is gonna present with cough as well as with low grade fever, right? I would say not always. The patient won't always have cough, right? uh, you can present with night sweats and fever only as well, right? So it's a combination, right? Sometimes it's going to be night sweats plus fever, right? Something is going to be cough, right? But yes, cough is like a telltale sign of TB, right? If you're having a chronic cough, you have to get evaluated from TB, right? Apart, so what are the causes of chronic cough?
Weight loss. Oh, sorry, for TB weight loss.
Mm. So cough. What are the causes of cough? Chronic cough. Three I can think of is number one is asthma. Asthma is a very common cause of chronic cough. GERD is a very common cause of chronic cough, right? And upper airway syndrome is a very common cause of chronic cough. And then TB is one. So they test you on the chronic cough thing, right? They test you on the chronic cough thing again and again. That is why I'm going into this thing again and again. So asthma, GERD, upper airway syndrome, TB, sarcoidosis as well, right?
Smoking.
Yeah, smoking is gonna cause it as well, right? So it's smoking. Okay. So now,
Even
okay.
certain medications like the AC inhibitors, they even cause
Yes,
the cough.
yes. ACE inhibitors. Keep this thing in mind. ACE inhibitors are gonna cause chronic cough as well, right? It's gonna lead to cough, like, and so you keep that in mind, especially with Asian populations. Chronic cough is very common with ACE inhibitors. Okay. Um, okay. Any other questions, guys?
Thank you, Doc.
You're welcome. Okay, so let's go forward. Have you guys done sleep apnea?
Yes.
Okay,
We
so
did an
sleep up.
MCQ.
Hmm?
I don't
We
think we
did it
did
in
it as a
MCQ.
lecture.
You can still
Yeah,
go over it here.
I don't think we did it as a lecture.
We did it
No,
with Dr. Hasnan
Discussed.
in during the MCQ.
Yeah,
MCQ, yeah.
and it was vaguely discussed.
Right. Okay, so what is sleep apnea, right? Sleep apnea is very simple. You're gonna not gonna get any breathing, right? You're not gonna get any breathing for more than 10 seconds during sleep, right? And then you're gonna wake up from the sleep, right? And this is gonna repeat and again and again and again and again. And when you wake up a lot, right? You're not gonna get quality sleep, and you're gonna have daytime sleep. You're gonna have daytime somnolence. That's it, right? They're going to give you a patient, they are going to, so they are not going to say the patient wakes up from sleep, right? The NVM is a very clever, the ULD and USMLE is a very clever. They know if they say that the patient wakes up from the sleep, you are going to get a diagnosis of sleep apnea very soon. So they're going to say that a patient comes to you, they are going to give one risk factor of sleep apnea, and then they're going to say this patient is having daytime sleeping, right? And then they're going to ask what is the diagnostic step. The diagnostic step for this patient is polysomnography, right? So you're going to have polysomnography in this patient. Okay. So the patient is going to present with polysomnography, right? The diagnosis can be confirmed by sleep study, sorry, so sleep study or polysomnography, right? And then the patient is going to have daytime somnolence, right? There are three main causes of sleep apnea. We're going to go into the details one by one. So one number one is OS, obstructive sleep apnea, right? So what is obstructive sleep apnea? So basically in this thing the upper airway is going to get collapsed, right? So basically if this is your body, if this is a person, right, and they here they are muscles, right, and these muscles allow air to come, right, this muscle allow this thing allow air to come, right? So air is going to come from here, right? It's going to come in this way, okay? Okay, so air is gonna come here. Sometimes what happens is that this airway gets collapsed when you are sleeping, right? Because this muscle get collapsed, so you're gonna have sleep apnea, right? And then you're gonna have poor daytime functions, right? And you're gonna get poor daytime functions. You're gonna get less cognitive ability in the daytime, and you're gonna diagnose it with the help of polysomnography, right? Now, one important thing that is present here is that how does this thing happen? What are the risk factors? So the most important risk factor is obesity, right? When the patient is obese and the patient is having short, wide neck, which is known as the bull's neck, the patient is going to have it. So whenever they give you a patient, so remember, they like to test you sleep apnea a lot, and they're going to give you sleep apnea in random ways that you won't have even thought of. So remember, they can even give you sleep apnea. Like one situation is that sleep apnea could come with PTSD as well, right? They're going to give you a contrasting option of sleep apnea with PTSD. So basically, PTSD is post-traumatic stress disorder. So they're gonna say that the patient just so the patient went to a war, and now the patient is coming back from war, and the patient wakes up every time at night, right? And the patient wakes up 10 times at night, and you're gonna think since the patient went to war, and now the patient is waking up at night. This is post-traumatic stress disorder. But there's gonna be a indicator in the question that the BMI of the patient is like 40 or 50, right? And then you're gonna say, okay, you have to look at this thing. So look at this thing. The patient is gonna have a BMI 50. That means that the patient is having obstructive sleep apnea, right? There is obesity, there is a high BMI. Obviously, it's gonna be obstructive sleep apnea, right? And then they're gonna say sometimes that the patient snores, right? They're gonna give you this thing sometimes. Right? The patient is snoring, right? And so, oh, it could happen due to patient snoring as well. Okay. Is that clear? Or they can say the patient's neck circumference is increased as well. Right now, sleep apnea does not only lead to sleep apnea, it's going to cause a lot of other problems as well. Right? Sleep apnea is going to cause a lot of other problems as well. So, what is going to happen is that whenever you're going to have hypoxia at the night, right? Whenever hypoxia is going to be present at the night, right? The obviously, I told you, whenever you cannot get air inside. So whenever you cannot get air inside one of the alveoli, what is going to happen to that alveoli? No blood vessels there. Anyone? Whenever alveolar oxygen is low, what is going to happen?
Hypoxia.
Okay.
Collapse.
Constriction.
Collapse.
Yes. So there is
Hypoxia.
going. Yes, so there's going to be hypoxia, but there's going to be vasoconstriction of the blood vessels, right? So if alveolar oxygen is low anywhere, or if you think that the alveoli are not getting enough oxygen, right, you're gonna get hypoxia. You're gonna get vasoconstriction at that point, and pulmonary vasoconstriction is gonna lead to pulmonary
Pulmonary
hypertension.
hypertension.
And then for long terms, after some time, it's finally gonna lead to, what do you say? uh, it's going to lead to call pulmonary right-sided heart failure. At the same time, you're going to have hypoxia throughout the body, and when the body is having hypoxia, the body secretes erythropoietin. So that erythropoietin is going to get secreted, and then you are going to get increased amount of red blood cell formation. You're going to have polycythemia, right? Now, at the same time. So now you are having polycythemia, you are having hypoxia, you are having hypertension, and then body is going to secrete epinephrine as well to get the body into an active form, and then you're going to have systematic hypertension as well, right? Is that clear, guys?
Yes,
Yes.
doctor.
Okay, so this is obstructive sleep apnea, right? So yes, why?
What is the difference between obstructive sleep apnea and obesity hypoventilation? They kind of are the same.
No, so they are different. So different. I will tell you what's the difference between these things, right? Okay, so in obstructive sleep, uh let's first focus on the obstructive sleep apnea, right? So in obstructive sleep apnea, right? First thing is that so there's gonna be restless sleep. You're gonna wake up at night. You're gonna gasp. You're gonna choke, right? There is gonna be irregular snoring. There is gonna be apneic episode, and in daytime you're gonna feel sleepy a lot, right? You're gonna have headaches at daytime. All of these things are gonna be present, right? Now, uh, what is obesity hypoventilation syndrome? But which is known as the Pickwanian syndrome, right? So sometimes you're gonna have another thing, right? When you are very obese, right? Whenever you're very obese, the first thing that I told you, if a patient is obese, right? What kind of a other lung disease the patient can have with obesity? Anyone? What lung disease that we just discussed for obesity?
Restrictive
Obstructive.
lungs.
Yes, so the patient can have restrictive lung disease. That is the first thing. So patient who is obese, the patient is going to have restrictive lung disease as well, right? So the restrictive lung disease, the lung volumes are going to be reduced. There is going to be alveolar hyperventilation as well, right? And then at the same time, this patient is going to have increased worth of breathing, right? The patient is going to need increased amount of energy to breathe, right? The so you're going to have increased respiratory drive, and that is not going to be possible during sleep. So when you are going to wake up, that thing may be possible, right? But in sleep, that thing won't be possible, and you're going to have hypoventilation during sleep, right? So this is one thing, right? So now remember one thing. So basically, this is not obstructive thing, right? It's related to your energy levels and to your brain, right? Whereas in obstructive sleep apnea, everything is happening due to the structural problems. Here, no structural problem is present. Here, a problem of energy is present. So this is happening due to energy, right? So obesity hypoventilation syndrome is going to happen during daytime as well, right? So how do you differentiate between these two conditions? The easiest way to differentiate is to look at the CO2 levels, right? In obstructive sleep apnea, when you are not breathing properly at night, the CO2 levels are going to be increased, right? But in case of obesity, it's going to be normal during the days when you can breathe normally. But in case of obesity hypoventilation syndrome, since the hypoventilation or restrictive lung disease is present throughout the day or throughout every time, right? You're not going to get it during nights, but you are going to get it in during days as well, right? So if you are having hypoventilation during the days, or if you are having CO2 levels that are increased during the days, as well as the night, right? Then the most likely diagnosis is obesity, hypoventilation syndrome, or PIC variants. Right? But if it happens only during the night, then it's obstructive sleep apnea, right? Is that clear, guys?
Yes, yes. Thank you so much.
You're welcome. Right. Now we have a third thing, which is known as the central sleep apnea. Right. What is central sleep apnea? Central sleep apnea means this is the very sad thing, right? In central sleep apnea, so basically you have the medulla oblongata in your brain, right? Medulla oblongata is a structure that is present in the brain. So medulla oblongata generates your respiratory drive. Whenever you are near your death, again, whenever a patient is dying, the medulla oblongata starts to work slow, right? It starts to work not properly, and then the body does not get proper respiratory signals. Okay. Again, if a patient is having uh, medulla oblongata problems, then it's the brain is not going to function properly, and enough respiratory drive is not going to be sent to the body. This happens in heart failure and opioid poisoning as well, right? And eventually, what's going to happen is that the medulla oblongata is going to send the body is going to send the body a signal not to breathe, to breathe, right? And then so respiratory system only breathes when the medulla oblongata tells the body to breathe, right? If the medulla oblongata does not send any signal to the body is not going to breathe. Then for 10 or 15 seconds the body is not going to breathe, and then it's going to breathe again. This is known as the Kind-Stokes breathing or Kind-Stokes respiration. So this is known as the oscillations between apnea and hyperpnea, right? So whenever you are gonna see a patient that is in its terminal stages or dying, especially in old age patients, you're gonna have central sleep apnea for that patient. Is that clear, guys? Any questions?
Will we cover narcolepsy here or in
No,
CNS?
no. So narcolepsy is gonna be in psychiatry.
Thank
Okay.
you.
Welcome. Okay, so guys, so we'll take it till here today, right? And so tomorrow I think it's gonna be 10 p.m. Pakistani time. All right. Yeah, no. So it's gonna be 7 p.m. Pakistani time and 10 a.m. EST. Yes, Dr. Aksa.
Can you explain how the positive air pressure would improve the central sleep apnea?
Yeah, sure. Right. So did you get how would it increase solve the problem in case of OSA? I do have to explain that too.
No, I got that.
Okay. Wait a second. Okay. So let's go. So basically, I told you in central sleep apnea, there is no physiological blockages, right? Okay. So what is happening in central sleep apnea or kind of breathing? Let me go over a detail, right? Medulla is not working properly, right? Okay. So how does kind of breathing happen? Let me give you like a detailed overview of that, right? So these are the lungs, right? And if the lungs are not breathing for 10 seconds, what is going to get up and what is going to go down? Tell me, please.
Carbon dioxide would go up.
Yep, CO2 is going to go up, O2 is going to go down, right? So when the CO2 goes up a very lot and now suddenly the medulla starts working, right? How strong of a signal will medulla send? Less strong or very strong?
Very strong.
Yeah, so very strong signal, a very deep breath is going to happen, right? Will more CO2 go out with it or less now?
More.
More. So more CO2 is going to go out. So after this breath, the CO2 is going to be dangerously low. It's going to be very, very low, right? And now the CO2 level is going to go to the brain, right? And the brain is going to say the CO2 is really, really low. We need some CO2 in the body, right? And now, will the medulla send a signal from for the body to breathe or not?
Yeah, there's going to be hyperventilation.
Yeah, so it's gonna cause hyperventilation now. The medulla will cause the body not to breathe, right? And then for 4 or 5 seconds, the CO2 is gonna get up again, right? So then the medulla will send a strong signal. So just imagine of it like if this is your car lane, right? If this is your car lane, if these are two lanes, three lanes of the car, and you're driving in one lane, and you are not an experienced driver, what is happening is that your car is going to the right, right? All of a sudden you push your car to the left and you push it too much to the left. And what is going to happen is that again you're going to push it too much to the right and too much to the left and so on, right? So basically this is happening. The body is not functioning properly, and then you're having too much hypoventilation and hyperventilation, right? So what is going to happen with the help of positive airway pressure? When you're going to give the patient positive airway pressure, right? uh, there is going to be a steady supply of air. So kind strokes breathing happen in opioid poisoning as well as in congestive heart failure. In both of these conditions, you're going to see that the CO2, that the body is not getting a normal supply of air. The air is going to increase, the air is going to decrease, because in congestive heart failure there's going to be a lot of water in the heart as well, right? Water in the lungs as well. So what is positive airway pressure going to do? The positive pressure is going to open up the airways, right? And CO2 levels are going to be very steady now, right? CO2 levels are going to be very steady. So in congestive heart failure, sometimes you're going to get high CO2, sometimes you're going to get low CO2. No, same in the opioid poisoning, right? Positive airway pressure is going to fix that. It's going to say, I'm providing you all the support, keep it stable, right? So no large CO2 curve is going to be present there, right? So a second thing, in case of congestive heart failure, the body is going to have difficulty in initiating or sustaining effective breaths. Why? Because there is increased work of breathing, right? So positive airway pressure is going to help with that. Positive airway pressure is going to say, don't worry, I am doing all the respirations for you, right? All the respirations for you is going to be present, right? Third thing, even if no respirations are occurring, right, the positive airway pressure is going to give more amount of oxygen to the brain, right? And that is going to solve a lot of problems as well, right? So this is how basically like positive airway pressure helps with what do you say, congestive heart failure. And so congestive heart positive airway pressure has a very important role in congestive heart failure as well, right? So positive airway pressure is a very good thing, and this is important, right? This is important. So I'm in the ICUs these days. I'm working with a lot of positive airway pressure patients, right? Which is a very good thing. But remember one thing, you can never use positive airway pressure in right heart failure, right? Positive airway pressure is contraindicated in right heart failure. Keep this thing in your mind, right? Can anyone tell me why? Why is positive airway pressure contraindicated in right heart failure? Anyone?
The CO2 is already very high.
Anything else? Anyone, guys? Why do we use positive airway pressure in right heart failure?
I think it increases the intrathoracic pressure so that it decreases the right venous return to the right heart.
Okay, this was good. Very close. Okay, let me tell you. Basically, so if you have two parts of the in the heart, one is going to the lungs, right? In right heart failure, the right heart cannot function properly, right? So whenever you give positive airway pressure, what is going to happen to the pressure inside the lungs? Is it going to increase or decrease?
Increase.
Increase.
Okay. So is everything clear till this? If yes, then I'll move forward to how does it drops because of the
Yes.
problem. Okay. So now look at this thing. The pressure inside the lung is going to increase, right? Will the right heart now face more resistance or less resistance from the lungs?
More
Yes.
resistance. Mm.
But the resistance to the lungs is going to increase, to the right heart is going to increase. Now right heart is going to need more amount of energy, right? The right heart is already in failure, right?
Mhm.
You don't want to give more amount of resistance to the right heart. So that is why in right heart failure, we cannot give the patient positive airway pressure. Because if we give the patient positive airway pressure in the right heart failure, then there are going to be a lot of very bad side effects for the patient, right? So in right heart failure, again, remember, no positive airway pressure. And one more thing, in left heart failure, positive airway pressure is very good. Can anyone tell me how?
Because it will counteract the pulmonary edema, somehow push more air in the
Yes,
alveoli.
how? How? Well, okay, so this is very similar to the previous thing, right? If this is your heart, right? If this is the lungs, right? Everything from the right heart is going to go where?
To the lungs.
The
To the
Into
lungs.
the
lungs.
lung. And from the
To
lungs,
the
where is it going to
lungs.
go now?
The lungs. It
The
comes back to the right
left.
side. The
It gonna
left side.
No,
left side.
no,
It's gonna
left
so
atrium.
left side, right?
Yeah.
So in left heart failure, do we have less blood or more blood in the left side of the heart?
More.
More
More
blood.
More.
blood.
More
Do we not?
blood.
Do we need more blood now or don't we? Do we need less blood now?
No need.
More.
No,
Yeah.
More
no.
blood.
So we need less blood, right? We need less blood, right? So how can we get less blood? So there are a lot of ways we can get less blood. We can use ACE inhibitors, that is going to diurese the body. We can use diuretics, that is going to diurese the body, right? Okay, so these are the ways you can do it, right? One other way that is very good, that is impressive, is that we can give positive airway pressure. When we give positive airway pressure, what is going to happen to the pressures in lung? Is it going to increase or decrease?
Decrease.
No. So
Increase.
no.
Increase, I think.
Yeah. So if I'm applying pressure to the lungs, will the pressure inside lungs increase or decrease? It's going to increase, guys. Okay.
Increase.
Yeah. So when the pressure is going to increase, right? When the pressure is going to increase, right? Right heart is going to get increased resistance, right? So right heart won't be able to push all the blood into the lungs, right? All the bloods won't go into the lungs, right? And there is going to be less blood in the lungs, and less blood is going to go to the left side of the heart, right? And that is going to fix the problem of pulmonary edema and left heart failure. This is the reason we give CPAP in left heart failure and we don't give CPAP in right heart failure. Is it clear, guys? Any questions? If not, we're just gonna keep it till here today.
I have one last question. Can I ask? I'm sorry.
Yes, yes, yeah.
With this right heart failure also happens in obstructive sleep apnea. There, can we give CPAP?
Okay, a very, very, very dangerous. Okay, so this is a very like dangerous situation for any patient, right? This is a very dangerous situation for any patient. Why? Because um a lot of patients with obstructive sleep apnea have sometimes get right heart failure in the end, right? And if they are having right heart failure in the end, we cannot give them CPAP, right? We cannot give them CPAP. So we have to like be very careful with them when to give them CPAP, when to not. We have to outweigh the risks or benefit, right? But the thing is, then as an internal medicine physician, right? If you are like an internal medicine physician, right? You won't you won't be able to make this decision, right? You won't be able to make this decision, right? So for this, like we usually have to consult a pulmonary attending, right? Because again, so let me tell you one other thing. A lot of patients in the ICU present with pulmonary hypertension, right? A lot of patients have pulmonary hypertension as well, right? And in order to ventilate these patients, whenever we are ventilating a patient, we have to give positive airway pressure, right? And pulmonary hypertension, again, in pulmonary hypertension, right, PAP, positive airway pressure, is contraindicated, right? So when these patients come, it's very hard to ventilate or intubate these patients. Why? Because we cannot give positive airway pressure, and for ventilation, we have to give the patients positive airway pressure. So this becomes a very, very dangerous thing to do, and we have to work around it or navigate around it. Similarly, in like case of obstructive sleep apnea, if the patient gets like right heart failure or pulmonary hypertension, then we have to deal with CPAP very carefully. Okay. Okay,
Okay,
guys. So
thank
we'll
you.
keep it
Thank
here
you.
today. You're welcome. You're welcome. So we'll keep it here today, and we're gonna start tomorrow. Tomorrow, I think the session is gonna be at 10 a.m. EST and 7 p.m. Pakistani time. Okay.
Thank you, doctor.
Thank you.
You're welcome. Take care, guys. Bye bye.